It's now my great pleasure to introduce my friend and colleague, Professor Colonel Retired Rakesh Chetley. Rakesh was formerly the Chief Psychiatrist of the Canadian Armed Forces. And I know he doesn't like long introductions, but I'll just say that he is one of the leading lights in PTSD research in the world, a strong part of the international collaborative that relates to the CINP and beyond, collaborating with Europeans, Americans, Asian partners. Made significant contribution to mental health within the Canadian Armed Forces, former mental health advisor to the Deputy Surgeon General, and later senior psychiatrist and mental health clinical advisor to the Surgeon General. Appointed as the Canadian Forces Brigadier Jonathan C. Meekins, CBE RCAMC Chair in Military Mental Health, appointed Dalhousie, Queens, and the University of Ottawa. Rakesh shares his knowledge wisely and generously. He has many publications. He's very well known for his work. He is the founder and chair of the Empatho Group, an AI-driven well-being platform, also the chief medical officer of Midicine Innovation, a biopharma company developing treatments for mental health and addictions. Rakesh, welcome, and thank you for being here today.
Thanks very much, Andy. It's great to be here. Always great to be here. What a great talk, Roxana. I just think the 3-MDR and ketamine, I think it does dovetail into a little bit about what I'm going to be talking about, which really is the evolution of PTSD treatment and how we learn more and more about the illnesses, we learn more about the science and how we sort of change our treatments. And what I think, what we'll start with is just thinking about the concept of PTSD. So some of us are of different ages, and when we first learned, some of us in medical school, it was an anxiety disorder, fear conditioning, and that was really the initial thinking of PTSD. Then we learned about parts of the brain. Then we learned about sort of how the neural networks work, and then how PTSD is in the whole body. And if we think about the treatments that have evolved over the years, they've evolved in the same way. So in the beginning, really, naturally speaking, in the 70s, this is kind of a bit weird, this podium here to stand on, I guess, but really PTSD for those of us in the West, and certainly in North America, it was about the Vietnam War, people coming back from the war, and they were having trouble. Some of them were using substances, there were suicides, there were things. And really, to contrast the Ukraine war, this was, hey, you're back home now, you're safe, you're not in a war zone anymore, it's over, it's post-traumatic, it's after the trauma. And really, in some ways, why are you still acting like you're still in the trauma? Because it's afterwards, right? So the idea of anxiety, is it like a phobia? That was the thinking at the time. And in 1980, really PTSD became part of the anxiety disorders in there. The idea of fear, the idea of sort of classical conditioning, fear response to noises, to bangs, to memories themselves. So in the early days, fear was the core driver and anxiety was the ongoing state. The key behavioral aspect at the time was avoidance. You're avoiding things cognitively, physically, you're isolating. So really thinking about sort of an anxiety disorder, and that's kind of the treatments for the first 10 years were really based on that. So trauma responses persist via conditioned fear and avoidance learning. So there were clear mechanisms that linked the cues to the symptoms. It kind of lent itself nicely to some of the older treatments that we used to have. So clearly, an exposure-based approach is the recommendation. The limitations, of course, and it became obvious to many of us that it didn't explain lots of phenomena, like the dissociation. So it does explain the person that's jumpy, that's always anxious, always on edge. But there's also people after trauma that just stare into space and they don't seem anxious, they're numb, they're frozen. So it didn't really explain that part. It didn't explain concepts like moral injury, the guilt, the shame, and all of those things that have emerged more and more. And really didn't explain, the physical and somatic symptoms. And lots of times, trauma people experience that. And the clinicians were saying, but what about my patient that has this? And really the idea that, people, they kept talking about the Vietnam vets and the World War vets having pain and illnesses and heart disease and diabetes, and kept saying it was lifestyle and not really a part of the illness. So it was a good idea, made sense at the time based on our understanding, but really in terms of how we go from treatment. Oksana mentioned nicely, but this is the only sort of real reference that I'm going to put here. But we realized by around 2005 that many of these evidence-based treatments that we had based on this fear-based paradigm were limited. And really, so Steenkamp and the group in US published something that we knew for years and this is in 2015, I believe, that about 60 or 70% of people after the evidence-based treatments, which at that time were things like cognitive processing therapy and prolonged exposure, the evidence-based treatment, 60 to 70% of them still had the diagnosis of PTSD. They still met the criteria. So the treatments, while they did work for some, for more than half of the veterans, they didn't actually work. So the idea to keep looking. So as time went along, so science evolved, people started to image, whether it's schizophrenia, whether it's depression, all of these things. And really at that time, it was sort of static. And I remember sending patients halfway across the country to have neuroimaging done. And really at that time, the idea was it's about a part of the brain that's not working. So again, you kind of reverse engineer the explanation of the illness based on what you see. And at that time, it was really about the amygdala, the alarm system in the body that was going off like crazy, scaring us. It was the hippocampus, which is the memory area, which is really where we remember things, because obviously it's about remembering something maybe too good, you remember it too well. And then the prefrontal cortex, the part that sort of shuts it down. So then we had, from this fear-based explanation, we now have a brain explanation of, hey, this memory is stuck too hard, it's sending off alarms, and then it's causing us, for some reason, the part of the brain that says, hey, you're safe now, you're back home, the prefrontal cortex that was offline. So again, the explanation was based on that, and really in terms of the dysregulated threats, the alarm system of the amygdala, the memory problem of the hippocampus, and then the prefrontal cortex being sort of offline. So this was a good way of thinking of PTSD at the time. Again, very popular in the early 2000s in particular. It was reproducible pre, post, after treatment. We would see the amygdala becoming quieter. We would see these things sort of improving. In some ways, it's limited because it oversimplified, and really the next slides are going to show a little bit about how it's not isolated areas that are the problem. It probably more has to do with how the areas talk to each other. And again, it didn't really cover what was happening in the whole body. It was still sort of stuck in the brain, and we know more and more now that things are in the whole body. So there's advantages thinking of it this way, but then there's limitations. Now, this is really the cornerstone still of most of the treatments that we think about when we think about the amygdala, threats or prolonged exposure, the therapy that we have by exposing people to trauma, whether it's in vivo or in imaginal, sort of the memories of it, the extinction to reduce the amygdala-driven fear, you're hopefully going to do that. Cognitive processing, the idea is to keep the process down. So a lot of the medications were aimed to target at these regions. Prazosin, sort of that we use sometimes for PTSD nightmares, which is an old antihypertensive drug, sort of by accident we found out, also targets the adrenaline overdrive that's related. And many of the medications were targeting, the treatments, medications and therapies were targeting the amygdala. Oh, it's not advancing, sorry. Oh. The hippocampus, again, it's the memory area. So a lot of the therapies, when we found that, a lot of the therapies, so prolonged exposure and cognitive processing therapy, try to de-link some of the memories and try to help people to remember in a healthier way. Eye movement desensitization and reprocessing, or EMDR, that many of us use. Again, the idea is to let's bring back that disrupted, that bad memory, fragmented memory that's associated, and let's try to reconsolidate that memory. Some of the sleep-focused interventions, again, the idea is let's improve memory by getting better rest. The hippocampus, again, responds in that way. And again, the prefrontal cortex, the idea of top-down regulation, strengthen that through therapy, strengthen that through different ways so that somebody can reassure themselves, settle themselves down when they become activated. So we started doing studies, in Toronto. One of the things, the MEG scanner, looking at the actual electrophysiology of the brain, and really we started off with studies much in the same way as the original sort of the MRIs were, where you would provoke somebody by asking them to think about their trauma. You'd show them pictures, you might play sounds and trigger them. Then you would see the amygdala, you would see things, so the provocation studies. And we did that in the MEG scanner as well, without the delay of the MRI and just sort of, getting things going. And really, what we found with a lot of people found that it wasn't just about the regions of the brain anymore. It wasn't just about the hippocampus or the amygdala or the prefrontal cortex. It was really about the connections between them and how they were working. And so at the same time, that's when neural networks became sort of very popular in psychiatry overall in all illnesses. So again, it's not just about the hippocampus or the amygdala, it's how these regions communicate, how these different regions communicate with each other. And this is a busy slide. I just got AI to make it for me. It was kind of just having some fun. So it's the default network, salience network, and the central executive network are the main important ones. And I'll expand a little bit on these again. And really the idea now is, instead of going from the region of the brain specific areas more into how the regions talk to each other, and talking about now it's a disease of disconnectivity and altered switching amongst these brain networks, particularly the salience network, default mode, and central executive networks. I'll talk a little bit about these. And really it's about how these networks function and how they communicate and how they function day to day that becomes disrupted in the illness. So a little bit different than just the region of the brain. Helps explain sort of the heterogeneity and personalized care, the idea that there are different presentations. It does make sense. It's not just one way of having PTSD. Network findings, it's hard to sort of analyze them because there's a lot of data. It's getting better with AI now as well. And they're less specific in terms of the original fear one was straightforward. You've got a fear, trauma, you have the reaction. Parts of the brain, networks can get a little bit more complicated in that way as well. And so just a couple of slides to expand on that. So the normal role of the salience network is threat detection, gives things meanings, you look around, you observe. In PTSD, it becomes hyperactive, so you end up seeing danger where there may not be danger and sort of hyper-acutely attracted to it. Instead of being able to move on to something, you may fix on it. The default mode network is what gives us internal reflection, helps us think about who we are in time and space. That gets disconnected, fragmented in PTSD. So now we've got the explanation for how we can be dissociated, have a fragmented sense of self that people often describe or experience. So a little bit quite more nuanced than that simple fear-based sort of paradigm that we had before. And then the central executive network, again, it's hypoactive, so that's the part that helps us to control ourselves, make sense of things, and this. Another slide sort of saying similar kind of thing. The healthy state for the salience network is adaptive. You're sort of able to switch from things to things, give meanings, move away from things. In PTSD, hyperactive, so you're constantly on edge and alert. The default network, again, is integrated and reflection. It's fragmented, dissociation and flashbacks. And then the healthy state, the executive network, has a strong regulation of our brain, of our minds, and it's underpowered in PTSD. So we have this inability to calm down and have that top-down approach to sort of take care of ourselves. And so really this was an exciting time when people saw sort of, hey, neural networks, so we're finding out how things are actually happening in the brain, and we're seeing disruptions. So hey, we're going to now find personalized, people's signatures. We can target parts of the brain using TMS specifically. For you, we can target one part of the brain. For somebody else, we can. And there are differences. We've seen that with OCD versus PTSD versus depression. And the idea is, the excitement of being able to sort of, give more personalized treatments. neurofeedback, EEG-based neurofeedback, again, sort of recognizing, which of your waves have abnormalities. Can we start to now target those through neurofeedback? And there's been work in those ways again. So again, we can see the evolution of the treatments sort of changing as our understanding of the illness changes, or our models of the changes. Then some people have sort of looked back at some of the older therapies and said, hey, are these working on the networks as well? And some of the imaging has showed that. So cognitive processing therapy, yeah, it really does look at the executive network and reestablishes a logical top-down control of emotions, so that aspect of things. EMDR is, again, works maybe on the default and the central executive network by linking those fragmented memories to the logical brain for processing. So the idea of, maybe some of these old therapies were working in the networks, which does make sense. Again, many of the treatments, our colleague earlier was talking about ketamine and how ketamine may work, and maybe it breaks down the cycle of negative rumination, gets people unstuck, so it works on the default network, which gives us our sense of self. TMS itself can be working on the executive, can probably work on other ones as well. Stellate ganglion block, I don't know if people have seen that, but it's an injection that's right there, which sort of blocks one of the ganglia, the nerves, sort of physically mutes the biological alarm system in the brain. So it's targeting specifically that alert system. Neurofeedback, again, we talked about an MDMA with the salience and the executive network. So looking at some of these newer treatments as they're evolving, they do seem to be targeting the better understanding of the brain and PTSD that's been emerging. Now, we went from the theory of anxiety, of fear, then we went to sort of specific parts of the brain, the memory stuck in the hippocampus, the amygdala alarms going off, and then right into neural networks. But there's been a movement all along, and I think when you want to talk about Bessel van der Kolk at the beginning with the body keeps score and going back even further, many people feel that PTSD, the mistake that we've always made is thinking it's a brain disease, it's in the mind. It's a whole body disease. And I think that's when we stop and we think back, and again, there are studies from World War I where veterans tend to die prematurely of all kinds of diseases. They have more heart disease, they have more diabetes, all of these different kind of illnesses as well that aren't explained by genetics, aren't explained by lifestyle. I put this slide up because it reminds me, I was at a conference, oh my God, maybe 10 years ago, and at that conference, for some reason, everybody, like half the talks were animal researchers. They were animal researchers, and they kept talking about the animal model of PTSD. And I said to them, with respect, this isn't an animal model of PTSD, it's an animal model of fear. Where you shock an animal and then get it scared. And so that was kind of an interesting thing. And then one of the people that had actually gone into Africa and observed the animals said, if you ever go, because our idea of this is, fright, flight, that the lion comes, the survivors are the ones that can run faster and they get away, right? That's what we've always thought about it, and that's where your fear response might come. But the person said that if you ever go to Africa to the water hole, all of the animals there, the zebras, the antelopes, they all have scars on them, which means at some point they were attacked and the lion did kill them. And so it got us thinking that really it's about surviving the trauma, right? So if their clotting factors didn't start going, they would have bled out and died. So the clotting factors, the immune system fighting off the infection from the scratch, all of this. So the idea is trauma survivors aren't necessarily just people that have this emotional fright, there's a physical threat as well. And so really, a lot of the immunologists, some of the immunologists that work with us in the military, we've been doing blood analysis for ages. And so the idea here is that PTSD is a multisystemic disorder that involves autonomic, endocrine, immune, and metabolic symptoms. It's not just a brain disease. So it links some of the mental and the physical health outcomes that we see, cardiometabolic risk, flame, pain, inflammation, which we see in our patients. It highlights the autonomic dysregulation, the HPA axis, immune involvement. And its limitation, it's a very broad construct, so it's hard to get specific when you start looking at this. And then the biomarkers are very heterogeneous, and we've been looking for 20 years for the magic bullet, the one blood test that's going to show it, and it's probably not going to be that. It's probably going to be a panel. And when we think about the illness in this way, there's the immune system. We actually, in Canada, in Toronto, we just analyzed Australian serum from the war in Afghanistan and Iraq, pre and post, and we've done some really exciting analysis of looking at this mixed, with correlation with the clinical outcomes. So elevated immune, inflammatory markers, immune markers. So inflammation is measurable throughout the body. It's not confined to the brain. We actually see it. The stress hormones, you could see the effects, the endocrine changes. The autonomic nervous system changes. We've always known the jumpiness that people are feeling isn't just from the brain, it's throughout the body. The cardiovascular system changes. Again, heart disease is really about inflammation of the endothelium. It's not really about blood vessels sort of squeezing too tight. So the idea that there is an increased risk of heart disease, and then just in terms of insulin resistance and all of these different kinds of ideas. Way of thinking about this, again, from a pathway and mechanism is, chronic stress signaling. There's glucocorticoid resistance, which affects the inflammation that's going on throughout the body. Immune brain, feedback loops, which keep the fear and threat circuitry going, which again maintains it. A lot of work, like in many areas in mental health, the gut and the immune brain axis, looking at sort of how the gut axis and the microbiome in the gut can change. And we can just see the long-term effects on many organisms based on this inflammation. So, again, treatment approaches. So we change our understanding, we change our treatments based on what we learn. So many of these treatments have been around for a long time, but if you're looking at sort of if there's problems in the autonomic nervous system, heart rate variability, feedback, biofeedback can help sort of regulate some of that, changes the vagal tone. Stellate ganglion block, we mentioned it, the injection can help with the autonomic sympathetic system. There's evidence-based interventions for inflammation immune system that could lower systemic inflammation. With trying different drugs, different medications, different things. Lifestyle and cardiometabolic risks. So again, one of the things that we should always remember as doctors is every single patient that I've seen, I've probably said, sleep better, exercise more, and eat better, right? Those three things, and they become important in this illness as well, because now, again, we have the evidence to sort of show that the illness itself drives things. There are ongoing studies looking at the gut and the brain axis, and then the brain body model, this trauma-focused psychotherapy, and there's somatic therapies that have been going around for a long time, and places like India, yoga is very much sort of talked about preventative, but also as a treatment. So these things have become more and more. Two or three of the, just about 5 minutes more than Andy, if we're good? Yeah. We talked about 3-MDR. I think the idea of, so some of these treatments arguably are sort of whole body, and they take an approach for the whole body. So 3-MDR, sort of the walking, being grounded, walking on the treadmill, seeing the screen in front of you. There's a somatic aspect to it, the movement. And Eric Remetten and myself years ago, we used to talk about how when you're treating veterans, they never sit still for the whole hour. They want to be moving. They get up, they start walking even if you don't do it. So coming up with treatments like this, so improving engagement, have the movement. And the movement's at around 5 kilometers an hour, 4.5, 5 kilometers an hour. So for 45 minutes or an hour, that's a good walk, right? EEG neurofeedback, again, looking at things, working on the actual electrophysiology. The idea here is sleep. Sleep can improve some other aspects of body, and sometimes with pain as well, you can see it. Deep brain reorienting, which is an interesting, it's targeting the subcortical orienting mechanisms in the brain as well. So the muscles, as they react before the fear response even goes, targeting sort of what's happening in the body. And again, it's a up-and-coming therapy, and we're doing sort of more and more research looking at this. And one of the things I think that, if we're talking about what's new, really it's the bottom-up versus top-down approach, right? Good old cognitive therapy, your thinking is wrong, learn to think this way, don't be afraid, you're safe now. That's that classic. And when we're talking about top, really we're talking about the top of the brain. We're talking about the cortex, right? So bottom up can be even lower parts of the brain, not just necessarily from the body. So deep brain reorienting, sort of from the brain brainstem, subcortical, and looking at sort of re-looking at some of the neuroimaging, some of the changes are right down sort of subcortical and things in the cerebellum even. So looking at that, somatic experiencing, heart rate variability, we've talked about that, 3-MDR, yoga-based therapies, breath-based. So again, you can see some of these that are changing, exercise-based interventions, and really what we've done is we've given legitimacy with this to a lot of the therapies that have been around for years and years, and we've kind of dismissed them as they're adjuncts. We can do them on top of the regular therapy, but some of these therapies are actually quite powerful and quite helpful. And I think it's interesting to think about over the years, because the anxiety disorder, we started with this top-down approach, but now the bottom-up approach is helpful for many people, whether it's first line or second line. It really depends on how they present. I'll skip this slide, and really in terms of looking at things then, over time, if you look at 3 or 4 different eras, but I like to think of it as 4 eras. There were fear conditioning, looking at the regions of the brain, looking at networks, looking at the whole body. And what we've had is, looking at this, we've sort of evolved our treatments based on that in terms of what we think. Initially just saying, hey, it's just like a phobia. How do I treat a phobia? I expose you, I extinguish you, all the way to the other end of saying it's a whole body disease. And I think, I don't like to think of one model replacing the other. I think what's going to happen if we move forward enough, we'll understand some patients fit one explanation more than others, right? Quite often, a person that's otherwise healthy, single, car accident, you get to see them a few weeks after the accident. They look very much like that fear-based paradigm. They look very jumpy, scared. They're scared to drive. They're scared to be a passenger. Get them back in the vehicle, and they often get better. But somebody that suffered, horrific childhood abuse, and they end up having sort of chronic pain, fibromyalgia, irritable bowel syndrome, all of these, they're very much the whole body kind of presentation. So I think when you look at, as we move forward, is our understanding there is going to help us to target the treatment. So I wouldn't say one replaces the other, because they're already talking about the same illness, but one will explain the other. So 4 models, fear conditioning model, brain region model, network model, and whole body model. And they've sort of each led to treatments and explaining treatments. And I think in time we'll be able to have people fit those. Thanks very much. We'll have a discussion.